Thank you, Mario, and hello, everyone. It's really great to be here to talk to you about evidence-based ACL rehabilitation. And I just need to say that I'm so impressed with the Swiss Sports Physio Association for doing this to gather our community digitally and also completely free of charge. So Mario was so kind to ask me to talk about evidence-based ACL rehab. And when we consider the evidence base for ACL rehab, then you might be surprised to know that we have over 4,000 scientific papers on ACL rehab, and we have exactly 0 scientific papers that directly assess how ACL rehabilitation interventions affect development of post-traumatic osteoarthritis. So in this talk, I will invite you to think about how ACL rehab interventions can improve long-term knee health. And I think if you looked at the title of this talk and you were surprised by the focus on post-traumatic knee OA, then you're probably not alone. Because even patients with ACL injury, they do not expect post-traumatic knee osteoarthritis. So of almost 200 people who awaited ACL surgery in Germany, almost everyone expected that they would have no OA or only a slightly increased risk of OA. But in prospective follow-ups more than 20 years after surgery, we see that half of these people will actually get OA. So nobody expects post-traumatic knee OA, but a substantial part of people will get it. Jackie Whitaker and Eva Roos are behind this infographic on what they call the post-traumatic osteoarthritis risk profile. And this details factors that are suggested to be associated with development of post-traumatic OA. So we have intra-articular knee injury, we have re-injury, especially to the meniscus. We have early return to sport, obesity, physical inactivity, muscle weakness and dysfunction, fear of movement, poor diet, inaccurate beliefs, insufficient and ill-timed exercise therapy, and joint dysplasia. And these are all associations, right? They're not necessarily direct causes of OA. But it's probable that all of these factors are working together in some sort of complex system to affect each other and to affect OA development. So these are all the things that we do not want after a knee injury. But then what do we want? So we want the complete opposite. We want patients who are informed, who have realistic expectations, who are strong, are confident, have a healthy body weight, who are eating well, are physically active, have a timely return to sport, and no additional injury. And specifically for ACL injury, we have a ton of research that tells us that we have problems with a lot of these things. And in terms of what we can do with rehab, well, this is a major problem. This is a study out of Utah in the United States, where 1/3 of patients had 8 or fewer rehabilitation visits after ACL reconstruction. I don't think it's reasonable to expect that we can achieve all of those goals with 8 or fewer rehab visits. This is from Perth in Australia, where almost half of patients had fewer than 3 months of rehab. 95% of patients had fewer than 6 months of rehab. And that leaves about 5% to receive something that resembles what's recommended in the guidelines, which would be follow-up for more than 6 months, plyometric exercises, and also support in the return to sport phase. And in this same study, only 30% of people had quadriceps strength over 90% of the opposite leg 1 year after ACL reconstruction. Now, compare that to what we see in patients who have access to high-quality rehabilitation. So already 8 years ago now, Dave Lagerstedt showed us that at least 80% can get symmetrical quadriceps strength 1 year after ACL reconstruction. So this is not mission impossible. It is possible to get there. So can better rehab reduce OA risk? We do not have any direct evidence of that yet, but what we do have is that we have these treatment targets, and we have evidence that we can change those treatment targets. And if we look more closely at the treatment targets, we see that these are all good things. So regardless of the link to OA. And that means that while we wait for more evidence in this area, I strongly suggest that you just keep on trying to help your patients be informed, have realistic expectations, get strong, be confident, have a healthy body weight, to eat well, be physically active, have a timely return to sport, and avoid additional injuries. I will, however, just draw your attention quickly to some really interesting ongoing studies in this area. This is the Super Knee study. It's out of Australia, led by Adam Culvener, Kate Crossley, Christian Barton, and team. And they're specifically looking at people who have combined injuries. So this is a risk group for OA. And people go into the study when they're more than 9 months after ACL reconstruction. And the intervention here is supervised exercise therapy and patient education. So this study, it's all about taking this at-risk group and then giving them a rehab and an education boost to try to improve their outcomes. Up in Canada, we have the Stop Osteoarthritis study, or SOAR. It's led by Jackie Whitaker and a really, really big team of good researchers. And they are looking at people who have a sport-related knee injury. And the intervention here is an online exercise-based program that is specifically designed to try to reduce these risk factors for OA. I'll also mention one of our ongoing intervention studies, Better and Safer Return to Sport After ACL Reconstruction, or BEAST. So with me in this Norwegian and Swedish collaboration project, I have Håvard Moxnes, Grete Myklebust, Lars Engebretsen, Mariana Risberg, Claire Ardern, and Joanna Quist. We are looking at pivoting sport athletes 6 months after ACL reconstruction who want to return to sport. The intervention here is bi-monthly testing, and then the patients will get guidelines for sports progression, and they will get prescriptions for gym or field-based exercise programs based on their individual results. So in this study, we have people coming in who have had rehabilitation in many different places. And I'll show you what their strength and their function looks like when we first meet them. Is that substantial changes happen, and they happen quickly after 6 months. So quitting rehab before 6 months seems to be just a really, really bad idea. A more reasonable expectation for ACL rehab is probably about 12 months, but the reality is simply that it's going to take however long that it takes. That means that maybe the best rehab intervention to improve long-term health is simply to do rehab. And it's really where we're struggling on a population level. So go over some other points as well. The second point here is information. And that is not because I think you can prevent away with information, but it might be a necessary component to get everything else to work. And information, of course, that goes two ways. So the patient will need information about their injury and about the possible treatment courses, but we also need information about their goals, about their preconceptions, and about their lives. And we want to do this as early as possible after injury. We really don't want to be 6 months in and then say, oh, by the way, you might get away. So how do we talk about this? Well, we explain that after an ACL injury, you are more likely to get something called osteoarthritis. And osteoarthritis, well, that is different changes that happen to the knee because the repair process in the knee is not working properly. So we have changes to the cartilage becomes thinner, there are changes to the bone becomes thicker, and you can get some more bone in parts of your knee. You can get more joint fluid inside the knee, and the capsule around the knee becomes thicker and more easily irritated. Some people, they have these changes, but they don't have any pain. But of course, it is possible to get stiffness and to get pain from osteoarthritis. And the really bad thing about osteoarthritis is, of course, that we have no way to reverse these changes. And therefore, we really want to keep the risk down as low as possible. So this then leads into a discussion about what we can do to reduce that risk. So we talk about reducing the injury risk to the meniscus and cartilage, about how it's good to be physically active, to eat healthy, have a healthy body weight, and that muscle strength is important to protect the knee. So this is where we start. It's not with return to sport. When we make a treatment plan with these patients, the first decision is actually if they want to change activities or if they want to return to pivoting sport. So return to pivoting sport, it seems to be associated with a higher risk of the injuries, regardless of what we do. If they do want to return to pivoting sports, we think the safest possible way to do that is to return after at least 9 months from surgery and after passing return to sport criteria, to have a slow progression in sports participation, and to continue injury prevention training for the remainder of their athletic careers. And at least my patients, they usually come back and they say that they want to go for option number 2. But these are the options that we discuss. The third point is about strength training. And that's both because so many people struggle with strength, especially quadricep strength after an ACL injury, and also because quadricep strength is suggested to be a risk factor for osteoarthritis. Just last month, we published a new study where we see that 1% increase in quadricep strength symmetry, so 1 LSI, is associated with a 4% reduction in the odds of having clinical OA after ACL reconstruction. This graph here, it really shows what you miss out on if you don't load the exercises enough. This is from week 8 to 20 after ACL reconstruction. We have one group here who progressed the strength training exercises from 30 to 20 RM, so the maximum load you can do 20 times. And the other group progressed from 20 to 8 RM. You can see the difference in the graph there. You will get much better results in terms of strength, in terms of power, if you progress to heavier loads. So we really want to move to strength training principles for healthy people as soon as possible. And that means that we have 2 to 4 sessions per week. Make sure the athlete gets enough rest, gets enough food. We progress from 20 repetitions to 4 to 6 repetitions, and we use the +2 principle for load progression, which I'll come back to. For every targeted muscle group, we have 3 to 4 exercises in 3 to 4 sets every session, and we also have a focus on unilateral exercises. And the reason for the focus on unilateral exercises is simply because there is so much compensation going on in bilateral exercises. The +2 principle for load progression is simply that you increase the load by 2 to 10% once the athlete can do 1 to 2 reps over the prescribed number of reps. So in the last set, they perform reps to fatigue. If they can do 6 and they're supposed to do 4, well, then we increase the load in the next training session. And if you use that principle and you combine it with training at 4 to 6 reps, you should effectively end up with strength training at 75 to 90% of 1 RM, which is characterized as heavy strength training. There's a lot we could say about muscle strength. I do want to mention neuromuscular electrical stimulation. In terms of strength, we get better results when we use muscle stimulation than if we don't use it. So this is a really valuable tool to have in your toolbox. And low load blood flow restriction training is another method. It's an old method that's become more popular in rehabilitation recently. This is a fairly recent randomized trial where they compared low load blood flow restriction training with traditional heavy load resistance training after ACL reconstruction. And they found no difference in terms of strength. So that tells me that if you can load heavy, then do load heavy. But if you can't load heavy, so if you have an increase in pain or in effusion, then low load blood flow restriction training might be an option. The last point I'll talk about is continued injury prevention training. And there are no studies specifically looking at this for people who return to sport after ACL injury, but we have a lot of high quality evidence that these programs work in a primary setting for all the largest pivoting sports that we have. And for young people who play soccer, I really want to highlight the knee control program, which led to a 64% reduction in ACL injuries and an even higher reduction for the athletes who were the most compliant with the program. And most of you know the types of exercises that go into these programs. So these are basic sport-specific movement skills, and the programs typically have exercises that target different aspects, so plyometrics, strength, balance, coordination. And for injury prevention exercises in any other sport, I would recommend that you check out the free app called Get Set. This app has a ton of injury prevention exercises for all types of different sports, so the major sports in summer and the Winter Olympics. And then we also have a big knowledge bank in the website called fittoplay.org. So it's good to check that out as well. So to sum this up, we have no ACL rehab intervention studies directly focused on the effect on post-traumatic OA yet. But what we do have is that we have plenty of treatment targets, and we have evidence that we can change those treatment targets. The most important rehab intervention is probably to do rehab. And this is where we're struggling at the moment. And to get all of this to work, we need to be good at information, strength training, and continued injury prevention. These are funders of ongoing research, and thank you also to sponsors of the OSTRC. Thank you.